It is my pleasure to explain the technique for an anterolateral ligament repair with suture tape augmentation. The materials required are straightforward as illustrated here. We use the 4.75 swivel lock as well as the black 3.5 swivel lock and appropriate suture tape. As seen here, the proximal origin of the ALL is being established just posterior and proximal to the medial epicondyle, and a stab incision is made through the iliotibial band. And using a hemostat, it's possible to push underneath the iliotibial band and make sure there are no adhesions, and you've got a clear arc of movement in the plane in which the tape will be mobilizing. The proximal fixation is then secured, drilling for the 4.75 swivel lock and then tapping using the green tap until completely flush with the laser line. The tape is preloaded onto the 4.5 swivel lock and steered gently in until flush with the cortex. This is advanced easily, and care is taken to make sure that the anchor is not left proud. The core suture is then removed, and this can be used later to facilitate the tape. Here the hemostat passes in the same plane. It then pushes to the skin about 1.5 centimetres below the joint line, midway between Gerdy's tubercle and the head of fibula. A vertical stab incision, approximately 1 centimetre in length, is made to allow the tip of the hemostat to pass easily. The core suture is then used to feed the fibre tape in one simple smooth manoeuvre. The final phase is to secure the tape distally at the predetermined point, approximately midway between Gerdy's tubercle and head of fibula. Using the guide, it's possible to drill and leave the drill in place to give a rough guide with regard to isometricity as illustrated here. With the foot in neutral, full extension is achieved and knee moved into full flexion. We can then proceed to tap. It's important to note that using the fibre tape, there's no reason to apply additional tension in the 30 degrees of flexion. We're looking to re-establish the native length of the anterolateral ligament, and this has been established. The challenge then is to measure the appropriate length rather than tensioning. Care is taken here with the 4.75. When you feed it through the eyelet, it is rather tight as the tape passes through, and it has to be steered gently. It is then positioned adjacent to the tap itself, and then using a marker pen, the laser line marks to allow for the additional depth of tape insertion when the screw is inserted, ensuring that no additional tension is applied to the construct at the final stage of insertion. The tibial positioning is more forgiving, unlike the proximal origin, which has to be established with some confidence. A final range of movement ensures that there is no additional constraint to the joint. The idea here is that this protects your anterior cruciate ligament and doesn't replace it. Overconstraint of the lateral compartment can result in meniscal pathology and pain. This is an effortless addition to your procedure and will no doubt improve your overall technique. Thank you.